Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Aly-Khan Lalani and Christopher Wallis.
Hello and welcome back to The View on GU. I'm Chris Wallis here with my co-host Aly-Khan Lalani. We're here in Chicago on a beautiful Monday morning and now about to launch into the latest and greatest in bladder cancer. So obviously over the last year or so, advanced bladder cancer has seen some really fantastic trial data. And I think we incrementally grew over the last couple of days here in our understanding of the disease and what we can do for our patients. So we'll start off in the metastatic space, go through some of the data we learned there, and then maybe roll into a bit of a perioperative discussion as well. So, the big trial that we saw here was probably data from CheckMate 901.
Mm-hmm.
Matt Galsky presented on the lymph node positive patients. You want to walk us through it and maybe discuss where we take it from here?
Yeah, absolutely. I think more than having new treatments, we kind of understand some deeper unpacking of these treatments and who benefited. So for the 901 trial, just to remind our viewers and listeners, this was a trial, again, largely by definition for patients who could receive cisplatin. The control arm of gemcitabine and cisplatin versus gemcitabine, cisplatin, and nivolumab, as well as the maintenance nivolumab. And one of the key takeaways from the initial data, which showed a survival benefit, important response rates, and CRs favoring the so-called triplet arm, was who are these patients? And so we know that for a long history in bladder cancer, patients with lymph node-only disease, it kind of makes sense, right? These are largely a disease that has responded well to systemic agents over the years, whether it's monotherapies or doublets. And, really the 901 trial was trying to understand this a bit better. And so at a high level, the lymph node only population was about 18% of the overall group. And that's, let's say, 1 in 5 patients on this study. But what they found was that whereas response rates for the overall trial was about 58% for the combination with nivolumab, a CR rate of, over 20%, that when we looked at the lymph node only population, their response rates, again, with nivolumab was about 81%. And, really a significant CR rate of 63% within that. That's driving that 81. And this was, again, all better to even the lymph node only with chemotherapy, because that's one of the arguments, well, they could get away with just chemotherapy alone. Again, a good response rate of 64%. CR rate of 33%. But when you think about what you can do with an added agent like nivolumab, I think it was really important to show that although chemotherapy can help these patients, who by definition will do well, still the added treatment with nivolumab in this trial was beneficial. And so unpacking that trial, some of the comments were perhaps maybe this is a refined patient population you might want to seek this kind of treatment with. I think today, when we look at how does this impact what healthcare providers might do tomorrow, let's say in clinic, it's still important that those who currently don't have access to Nivo Gem-Cis, who might get Gem-Cis or Gem-Carbo, should get maintenance avelumab, because they would, by definition, have a response. So current state, those patients have the opportunity to get IO, even if it's as a maintenance option. Larger question becomes a couple of things, maybe a bit about the future, which will be, what do we do with EV Pembro? And we'll get to that a little bit later. But from a medical oncology perspective, Chris, if we give this treatment, let's assume it's Nivo Gem-Cis, inherently patients that can get cisplatin, and I were to come to you and say, listen, we have a CR here. I see radiographic CR. The patient is asking about maybe definitive/curative intent treatment now that they've been treated in a metastatic setting, but had a significant response, were lymph node only. What is your thought if I came to you as a urologist and said, look, can we look at more definitive options? I mean, how would you take that? Unanswered today, but this is provocative. What are your thoughts on that?
Yeah, I think it's a great question. And I think, we really have to think about what the intent is when we put people on the maintenance approach, right? So if you have your induction, either chemotherapy or chemoimmunotherapy, and you're putting on maintenance, I think our goal is to hold patients without disease for a period of time, acknowledging that it's not really a curative intent. And so the question then is, can we take these patients who've had a great response relatively low burden of metastatic disease to begin with, and then a great response to their systemic therapy? And can we truly bring the idea of cure to the table for them? And so, that's local consolidative approaches. So that could be surgery with probably a reasonably extensive nodal dissection, or even radiotherapy. And are these options on the table to really give the patients an opportunity for more durable disease control? And I think that's certainly a bit of a data-free zone at this point. We don't have strong approaches, but the more systemic data we see and benefits from intensified systemic therapy, it kind of takes us in two ways with local therapy. One is, maybe you need less local control because you've got such good systemic agents. Alternatively, you maybe are turning disseminated disease into a more localized disease where a local therapy actually has more benefit. And I don't think we really have the data to understand that, but it really offers opportunities. And then the question then becomes, if you want to pursue this approach, when do you pursue this approach, right? The notion here in 901 is for maintenance nivolumab out after your induction period, or in Javelin, right, maintenance avelumab. And so when do you do it? I generally like to see a period of stability, right? You don't want new metastatic disease popping up. And so, you're not keen to jump into surgery right after an induction phase, but is the answer 3 months, 6 months, 12 months? I don't think we have data to inform that. And this is where I think those multidisciplinary consultations, your tumor boards are really critical, because this is clearly not a blanket treatment approach. This is a really patient specific and personalized decision.
Yeah, I mean, and just to remind our viewers and listeners, by definition, we are talking about patients who had, de novo bladder cancer, metastatic disease responding well, have the bladder in situ. And as you say, you could argue and say, should we leave it alone, bring it back to multi-D? Maybe there's a radiation component that we could do. Maybe we could look at a surgical component. But I like that really in this multi-D vein, we bring these patients back because, of course, if they don't have access to nivolumab and it is a maintenance avelumab approach, I agree with you. Keep that systemic treatment, get it going, prove that sustained stability. But the patients want to know, in the words of Lloyd Christmas in Dumb and Dumber, like, so you're telling me there's a chance? Like, you're telling me there's a chance that I could have now my metastatic disease treated more definitively localized? And I think they want that opportunity. So by no means have we answered that today. But I agree with you. I think the consolidative approach, we are seeing this. We are seeing this in patients. And it's a question that will probably live with further advancements in first-line treatment. So yeah, I'm glad we can keep that conversation going. I thought that was interesting.
Absolutely. And I think, when we think about where we're going next, the obvious question of bladder cancer always comes back to EV plus Pembro. And we saw two good presentations this morning that maybe help us figure out both how we counsel our patients from the patient-reported outcome side and maybe some good reminders around dosing when we look at cumulative exposure and outcome relationships. And maybe you want to walk us through those two?
Yeah, I think two that stood out was the EV302. Shilpa Gupta presented the so-called PROS, or patient-reported outcomes and quality of life data. And then we had Dan Petrolak present the exposure of enfortumab, admittedly in a single arm, potentially, or pre-treated setting. So let's start with the upfront EV302. I think we have and others have well documented how well patients have done in terms of progression-free and overall survival as a new standard of care. As of this recording, not routinely available in all countries around the world, but is coming. And certainly we hope in countries like Canada and others in Europe that throughout 2024, certainly by fall, we'd have an answer. But part of the data that was presented was showing the quality of life. And I think, we're hot off the presentation, so just to make sure we have this accurate, they did show patients who had already moderate to severe, pain at baseline, that we saw some change in worst pain through their short form BPI forms, that perhaps, these patients largely were maintained. Perhaps there was some improvement in these scores. I would say it's fair that it's quite similar when patients have a cancer that appears to benefit from treatment, whether it's chemo or EV Pembro. These patients do feel and function better. Certainly doesn't look like the interventional arm here harmed patients. in the pain perspective.
And that's importantly, that's 1/3 of the patient cohort, right? You're talking about
exactly. And so
it's a subset. Yeah.
These are, when you think about it, which patients are showing up brand new caught bladder cancer, either de novo or recurrent, that are in pain. You might think these are largely bone predominant or bone involved disease. So it's not exclusive to them, but certainly that would be a patient population. They showed that some of these change in EORTC, these QLQ, these kind of surveys from Europe, that again, in the patients that had moderate to severe pain at baseline, that these subscores appear to improve as patients get good treatment. And in the functioning domains of role, physical, what we call social, cognitive, emotional, all these other functional domains appeared to favor EV-Pembro. I mean, I think it's perhaps not a surprise, although nice to confirm that if you have advanced cancer and you get good systemic treatment, your patients will largely appear to feel and function better. I'm not sure that has necessarily reaffirmed or taken away from EV-Pembro as a pending or standard of care that's coming. So I think good cancer control leads to good quality of life. I will say, I think the presentation from Dan Petrolak showing that in a variety of enfortumab trials, 201, 301, et cetera, it looked like that patients who had more kind of exposure, either through quartiles, exposure of drug, however you want to codify it, that these patients appeared to do better. And from medical oncology side, I draw the analogy to TKIs. So, we know that dose and schedule individualization helps in kidney cancer with TKIs. I think within enfortumab, what we've shown is that in this 3 weeks on, 1 week off dosing in a pre-treated setting, so again, this is subsequent line, that patients who get a good dose, have some toxicity, and perhaps need dose reduction, inherently those patients probably got exposed to a good dose. Obviously, we want to reduce the harm to patients, but in those patients, it looks like they seem to benefit the most. So we can say that, if you go too easy on the patient, it might be too easy on the cancer. That's one way. Another way you might want to look at it is, we want to squeeze everything out of this toothpaste tube of treatment. So if you started that dose, which again is 1.25 as first dose, 1 and then 0.75 and then 0.5 milligrams per kilograms for each individual patient. But if you generally start there, and they had some nice graphics showing who started there and how long did that go. One of the challenges about those figures is that as you go out towards cycles, the numbers at risk or eligible at the bottom drops a lot. So the shadowing, you got to look at the numbers at the bottom. But I think the real message should be that when you give this drug, obviously we want to get experience with it for those that don't, but start at a good dose, really the recommended dose, and you have the opportunity to hold, pause, dose reduce, and give more patients time on therapy. The final piece I would say that is not well captured or we need to keep an eye on is some of these toxicities like fatigue, like GI upset or diarrhea can be maybe abated when you pause and change doses. The key thing, though, to remind folks again is neuropathy. This is one, whether it's peripheral, whether it's motor, or whether it's autonomic, doesn't abate necessarily quite so well. So to be careful that as you try and give a good dose to your patient, that's a side effect you keep an eye on. So I think that's really how I interpret kind of the quality of life / drug exposure to enfortumab, either in a pre-treated or a first-line setting. But why don't we pivot, Chris, to the perioperative setting? Truly multi-D, right? Standard of care is neoadjuvant cisplatin-based chemotherapy onwards to definitive treatment. We have lots of good data showing that we really apply that in our clinics to either patients that go on to surgery or radiation. So that's the standard of care. Take us through some of the data on a novel agent used in patients who perhaps weren't cisplatin eligible or interested. And this is sacituzumab govitecan, the SURE trial. What stood out to you? This was, I think, it made a lot of headway, a lot of noise. Take us through that.
Yeah, I think it's important to level set here that while we think neoadjuvant chemotherapy followed by surgery is the standard of care, many, many patients are not cisplatin eligible, and a non-cisplatin neoadjuvant approach isn't recommended. And so it leaves a large proportion of patients who need something else. And right now, most of these patients are just going straight to surgery. They're not getting the benefit of neoadjuvant therapy. So the idea of exploring alternative approaches that can be given in a cis-ineligible population in the neoadjuvant space, I think is a really needed approach. really a valuable approach. And so the real question is how this trial fits into many others. And there's been a lot of work in recent years in the neoadjuvant IO space, mostly single agent IO. And unfortunately, we haven't really moved the needle. I would say the easiest endpoint here is pathologic CR, right? And so when we think of PCR rates, we haven't really moved the needle a lot, moving from our old standards to something like, neoadjuvant pembro or other IO approaches. And so the idea of using an ADC here, I think is really appealing. And so we can talk a little bit more of the sort of advanced disease space context of why SG may be a good option for certain bladder cancer patients. But this was, in this study, a really small, early approach in a sort of 2-arm study. SURE-1 looking at just monotherapy, SURE-02 looking at the combination of SG with pembro in that ineligible or a refusing neoadjuvant population prior to cystectomy for muscle-invasive bladder cancer. And so the planned approach here was 4 cycles of SG in the 0-1 cohort as monotherapy with radiographic response assessment followed by consolidative surgery. And that was the intent. And there was a goal to enroll about 20 patients or so. They got 3 patients in. In the first 8 patient lead-in, there was pretty significant morbidity associated with this approach. And so I think there's some learning for all of us here. In the first 8 patients, there was 2 deaths, 1 deemed treatment related, 1 deemed not treatment related. Of the remaining 6, all of them had grade 3 or 4 neutropenias, similar magnitude of diarrhea, and they all required dose reduction and then the use of GCSF. After those 8, those dose reductions and sort of marrow support were applied, and the trial was able to roll forward. But before we get maybe into the data, walk us through your thoughts on how we use this drug, and then we can maybe circle back on what patients can expect if we can get them through the neoadjuvant phase.
Yeah, I think right away when we saw that, we were struck that 2 out of 8 patients initially having on trial grade 5 event death is striking. I think from a systemic therapy perspective, because we're all going to work together, especially if these drugs are perioperative and sharing patients, really important that the 10 milligram per kilogram dose is appropriately adjusted to 7.5 milligram per kilogram, and likely would be the right way to move forward when we start potentially combining this drug with IO or other ADCs and IO. So I think that was one really big takeaway. And as you mentioned, now making a primary prophylaxis inclusion of GCSF, again, largely available in many countries routinely for patients, was also very important. This is a, as you said, a curative intent patient population, maybe cis ineligible or uninterested, but still suitable to go for surgery. So really important that we offer all the support we can to these patients to get through. So I think the real takeaway from a systemic therapy, the 7.5 milligram per kilogram dose and GCSF. So admittedly with that, Chris, what did you take away from once we got out of that first phase? 18 out of 21 patients completed these cycles and underwent 11 patients underwent radical cystectomy. What did you take away? Obviously, it wasn't everyone. So some patients didn't, which is another question that comes from it. But, what did you take away from that remaining data of patients who could go through this?
Sure. Well, I think there's 2 takeaways, both the patients who opted for surgery and those who opted out of surgery. So those who opted out of surgery are maybe the more interesting to me, to be honest. One of them had disease on radiographic assessment and maybe ought to have gone for surgery, but the remaining had no evidence of disease on radiographic assessment with cystoscopies, with MRIs of the bladder. And so those patients appear to have been cured, theoretically, with the systemic therapy alone, monotherapy in a muscle invasive bladder cancer context. And so this really raises the opportunity for the ideas of bladder preservation, I think, and it opens up a new opportunity there. And so supporting that, I suppose, is that in the cystectomy cohort, we had a 36% CR rate. And if you take into account those other patients who didn't go for cystectomy, but on all forms of assessment appeared not to have any disease, we see a pathologic CR rate rise to like 48%. To be in the like 48, 50% pathologic CR rate, I think is really a step forward compared to where we are with other neoadjuvant approaches for this cis-ineligible population. So I think it does offer opportunity. We saw other poster data here suggesting that if you add some IO to some ADCs, maybe we can bump that pathologic CR rate even higher. But I think, once you get into really meaningful pathologic CR rates, you then have to reconsider the question of, do we need to consolidate? Does it need that cystectomy? Or can we get true bladder preservation here with good systemic therapy?
Yeah, I think this is again why it's so important to be multi-D. I know both of our centers were quite fortunate to have multi-D bladder clinics where we can have that baton going back and forth between medical oncology and uro-oncology, radiation oncology where appropriate. So learnings from this study, as you said, themes of a multi-D care. Patients are clearly asking, why do I need to do anything to my bladder? Or why do I need to cut it out? So I think we have to be nimble too with the field. Just to kind of come full circle on the sacituzumab, because you brought it up as, this might be an active drug. I think there's no question it's an active drug. I think full disclosure, May 30th, right on the brink of ASCO, there's a press release about the phase 3 TROPiCS-4 data. This was felt to be the confirmatory, so-called confirmatory, phase 3 data, building on the phase 2 data for sacituzumab, where this study was looking at sacituzumab govitecan in patients post-platinum, post-immunotherapy, much like other ADCs we have out there. Unfortunately, the study did not meet the primary endpoint of overall survival in the ITT. We will obviously be closely watching this. I think it does bring, lots of questions already we have about trial design, patients that entered, that perhaps our perceptions of ADCs, especially in terms of what they target, importantly, the linker and the payload to some extent, how they differ. We had shown that they could be combined, and we're already racing towards trials looking at ADC plus IO. So I do think we will take some pause and see what this phase 3 trial showed and really evaluate the future of sacituzumab. And, it's undergoing a lot of evaluation, but this phase 3 trial being negative, I certainly think, look, it does put a damper on what we wanted to see in this patient population. But, I think that's going to be really important as we look forward. And look, there was a lot more we could get to. There was, rapid orals and posters looking at alternate histologies, locations like urachal cancer. So, lots of good data there. But, we're hot off the press and trying to keep everything that we thought was really important. So, I think we've covered that. And hopefully folks who are watching this will be, keen on our kidney podcast as well as our prostate podcast. So more to come. On behalf of my co-host, Chris Wallis, I'm Aly-Khan Lalani. Thank you so much for watching, and we'll see you on the next episode of The View on GU.